Well, welcome. This is Jason Helgerson. I'm joined by John Olberg, and we're pleased to do a webinar today looking at some of the highlights of this year's 2018-19 executive budget, as well as provide an update on the global spending cap and Medicaid. So pleased to be here. And in addition to this presentation, you will also find a copy of the we call the scorecard for the Medicaid global spending cap budget proposal, which hopefully between this presentation and that document, we'll be able to answer most of your questions relative to the governor's proposed budget, but obviously also happy to answer questions from individuals or organizations on an as-needed basis going forward. All right, so in terms of agenda today, we're going to look at the results of our spending under the global spending cap through November of 2017. We're now at a point where we've moved into what we call closeout, which is getting ready to close out the fiscal year. We are on pace to live within the confines of the global cap, as is often the case. It'll be a little bumpy here to close out, but we believe we have a path to close out and live for another year within the confines of the cap. But we'll give you a little breakdown in terms of where we are today, or we're through our actual expenditures through November. We'll also talk about the global cap projections into 18-19. You'll see a chart that is very familiar for those of you who've been following us for a few years, talking about what's driving up increased costs within the global cap, what we've had to accommodate for. So we'll go over that as well. Next, we'll get into, it's kind of hard to believe to say it, but MRT Phase 8, our, in essence, 8th budget cycle is where we are in, and that is the governor's proposed budget for 2018-19. Generally speaking, overall, the budget is being presented, proposed in much the same way as it has in the past, the 2-year appropriation, overall structure. The budget is global cap neutral. Meaning that we have to live within the confines of the allowable growth, the 10-year rolling average, the medical portion of CPI. And as usual, you will see a series of savings initiatives, efficiencies, proposals that help us live within the confines of that cap. And you'll see, although this year, a little bit less than in previous years, some investments, areas where we think we need to actually increase expenditures to achieve the goals of the program in terms of improving outcomes and lowering costs long term. We'll also talk a little bit about the minimum wage increase. It's a substantial increase in Medicaid expenditures being dedicated to address provider increased costs due to the statutory increases in the minimum wage. We're very excited about the minimum wage going up to $15 over several years, but we understand full well that it has Medicaid provider impacts, and so the governor stays true to his commitment and funds the Medicaid share of those increases. And then lastly, we'll talk about the pressures and risks, and we'll talk about next steps in terms of answering questions on a go-forward basis. So with that. So what I'd like to do now is turn over to John Olberg, the Chief Financial Officer for the Medicaid program, to start talking about this year's global cap. And how are we doing, John?
Well, so far I think we're doing okay. I think, as I probably say every year, right, the closeout is a challenge, and I'll say this year is no exception to that. You can see down at the bottom right-hand corner that we look okay to the tune of $17 million, right? This is kind of the way we lay out our spending and record our spending in our monthly reports, but the first column is the estimated spending, what it's actually coming in at compared to the model, and then there's the variance. I will say, right, at the mid-year, we do another look at the model and make corrections as needed. Starting in August into September, we started to see quite a bit of pressure in terms of new enrollment in the MLTC program, and also on the fee-for-service side, even saw some increasing expenditures there within long-term care. So those were in the neighborhood of $300-some-odd million, plus we're seeing some increases in Medicaid managed care. Within the categories, seeing a different mix of patients entering Medicaid managed care. We're seeing, some increases related to low birth weight babies and such. But the good news is that we've got offsets against those spending increases that we've now factored into the model, the big one being a credit that actually we're going to receive from the essential plan related to what we call the medical loss ratio. And that will cover the bulk of it, plus we have some other actions. But as we sit here today, looking forward, we think we'll be landing okay when we hit March, but nonetheless, quite a significant challenge. Next slide. This is our enrollment chart. I don't think we ever thought we'd be seeing this or saying this, but we actually are seeing enrollment decrease by 794 recipients since April. And obviously, from a spending perspective, I think that's good news. I think in terms of enrollment coverage, that's also very good news. We're at an all-time low, I think, in the state in terms of our uninsured rate, and the Medicaid program and the essential plan has played a very significant role in that. Hidden within the numbers, though, as I had indicated, is down at the bottom corner. You see that little footnote where we had 21,000, a growth of 21,000 individuals in MLTC, and those folks are expensive in the model as you compare it, to the mainstream program, and that's again where the spending pressure lies within the numbers. It's interesting at the bottom line, you can see New York City actually had a drop of 3,400 individuals, and we're seeing an increase in the rest of the state of 2,600. All right, moving on to 18-19. Looking forward here, the global spending cap, according to the formula that was put in place 8 years ago, will reach $20.8 billion. That reflects a growth of $1.2 billion, including $448 million in minimum wage adjustments. That's in essence a transfer that comes over from the general fund. But rather significant increase. Our initial approach at looking forward to next year is we kind of bucket the expenditures into the three major categories of price, utilization, and what we call one-timers. Within price, it's $1.7 billion. That's a significant growth rate. But you can see to the side our initial estimates of where we see base and trend going within Medicaid managed care, 3.5%. That's a good placeholder for now, $321 million, and 3% for the MLTC program, $183 million. Now, I think we have a new actuary who's working with us. We presented to the plan last week. We are on target to have good, solid numbers as we enter into April, which is a relief. So we'll have a better fix on the biggest component of spending within the program before the start of the year. We also have some fee-for-service packages. These are just packages that we customarily do every year for capital adjustments and case mix adjustments and the like. And I had mentioned minimum wage year to year is going up $448 million. Moving on to utilization, the way the model works is when you had people enter the program in 17-18, you have to, in essence, annualize those expenditures because they're in the base for a full year now. And then we have actually forecasting modest growth. We're hoping things flatten out within MLTC, or the growth rate flattens out, and we have built in 8,400 new individuals for MLTC. On the one-timers, I think this is the last year of the ACA enhanced FMAP that continues to benefit us. We have some increased spending in state ops that we're forecasting, new CFCO services, and we have a modest increase in PCMH. And those all net out to a negative $117 million. And with that, I'll turn it back over to Jason to kind of run through the specifics of the proposals that we have in phase 8.
Sounds good. Thanks, John. So as John said, we've got a number of global cap pressures this year. I would also highlight what John talked about on managed long-term care. That's really now become the #1 driver in the program. Actually, it's eclipsed pharmacy, which we've said previously was the #1 driver. It's enrollment growth. We've looked at it in a number of ways. At this point, it seems to be that the people who are signing up are truly disabled. Case of, in fact, the disability level of disability within the program is actually increasing as over the last few years. So it's just a challenge. As we move forward, you'll notice a number of initiatives that are targeted at trying to slow this growth rate. but I think it's just something that we have to be watching and concerned about on a go-forward basis. So as you can see here, this is just at the high level. I'll get into the specifics of the different types. We have some of those global cap pressures that are making our challenge more significant going into this next year and the year after. And then you see our plans for how to basically balance the global cap through some efficiency measures. Next slide. So in terms of global cap pressures, first and foremost, we're providing the global cap, as has been the case in previous years, financial plan relief. This year, that relief is $425 million, up from about $300 million last year. I think it's been well documented. The state's facing a real budgetary challenge this year. Budget deficit about double what it typically has been. And so in that environment, it's not unheard of to think that they would be looking to one of the largest utilizers of state resources, that is the state Medicaid program, to help support addressing the overall budgetary pressures. Also, we have a number of federal obligations. Most of these are very old OIG audits that are sitting out there that we'd like to begin to resolve. We've allocated funds, $175 million, to begin to really address some of those obligations on a go-forward basis. Next up is VBP QIP and the VAPAP programs. These are payments to support financially distressed hospitals as they move into value-based payment arrangements. This is a performance, particularly the VBP QIP program, is very much a performance-based program designed to facilitate a smooth transition of safety net institutions into the value-based payment world. The needs of that program are growing, so we're increasing funding by about $45 million. And then there are just some other global cap pressures that in aggregate add up to $30 million. Essential plan. So I think it's much been documented that there was a significant impact in the last few months on the essential plan with the federal government's decision, Trump administration decision to end cost sharing reductions, which is an important revenue source, into the essential plan. The essential plan has been a tremendous success for New York. It's been a key reason why we've been able to bring the uninsured rate down to now less than 5%. More than cutting the rate in half statewide. Over 700,000 people are now enrolled in the essential plan. It covers individuals' incomes of 138 to 200% of federal poverty, and it's been really a great boon not only to individuals but also to the global cap, because it saved the global cap some money, because it allowed us to transfer into the essential plan a population that historically had been on Medicaid with state-only funds. But that said, the loss of those cost-sharing reductions punched a hole into the global spending cap. So people ask why. Well, it's because the essential plan backs up into the global spending cap. Those two are intrinsically linked. And so it created a significant budgetary challenge for us, for the governor to overcome. The good news is that we were able to make structural changes within the program, particularly as it relates to reimbursement rates to health plans, designed to protect coverage for the individuals who are currently on it. There are no changes in eligibility. There are no changes in the benefit structure or cost sharing proposed in this budget, but rather changes in reimbursement, which our actuary and ourselves believe are appropriate, that will allow us to not only absorb the loss of the cost sharing reductions, but also to shift some of our supplemental programs, which historically have been part of Medicaid managed care, into the essential plan. So I also mentioned here that if there is a risk in this overall approach that we are proposing, the biggest risk is the risk around what will happen to the second lowest silver tier plan in 2019, next calendar year. We won't know what those are until the summer-ish time when plans submit their, in essence, bids for next year's rate cycle. But the second lowest silver tier plan helps to calculate what the tax credit amount is, which is the primary revenue source into the essential plan. Because of a number of factors, in particular, the elimination of the individual mandate, we are anticipating a pretty substantial increase in that second lowest silver tier plan. In fact, over 20% increase in that to account for the fact that insurers will want to seek higher rates from the program in order to be able to justify the fact that, or to address the fact that they probably will have a sicker population in the face of the individual mandate being eliminated. So, but all of this means that there'll be more tax credit revenue coming into the program, which allows us not only to helps us not only absorb the loss of the cost sharing reduction revenue, but to shift Medicaid expenditures out of Medicaid into the essential plan. This will have basically no impact on the providers participating in the program. It'll just be a different program that we'll be using to administer things like the VBP QUIP program. But that is a big part of how we are solving for this year's global cap. Next slide. All right, so I'll go into the individual sections here. Pharmacy initiatives. As always, we are always looking at the pharmacy benefit to see what we can do to achieve efficiencies. Once again, number of proposals here. First and foremost, a sort of omnibus proposal around inappropriate prescribing and enhanced prescriber pharmacist collaboration. Included in this is the elimination of prescriber prevails and also establishes a voluntary comprehensive medication management program. We think there's a lot of opportunity for stronger collaboration between prescribers and pharmacists to make sure individuals are getting the right appropriate care and also understand how to manage their prescription drug needs, especially those with very complex who have multiple comorbid conditions. Next up is reduced coverage for OTCs. We identified some opportunities to basically narrow the covered list of OTCs. We don't think this will have any impact on individuals. If those individuals need drugs in certain areas or for treatment of certain things, there are also brands available in certain areas. And we do increase copays for the OTCs from 50 cents to $1. Next up is a rebate risk assessment. And so we've been very focused. In fact, I know that the State Controller's Office has been focused on making sure that we are collecting all the rebate revenue. It's a little bit of a complex undertaking because we rely on the health plans to submit data to us, and then we have to submit it to the federal government. We have a new contractor engaged in helping us in this, and we think as a result of those efforts and some new billing and collection protocols, we're actually going to be able to increase our rebate collections by a modest amount of about $10 million. There are some other pharmacy initiatives you'll see on the card as well. Next up is long-term care. As I mentioned, it's the #1 driver now of expense in the program. We're still trying to figure out exactly what's happening here, but we know our growth is greater than it is in some of our peer states. Part of that's because New York has no caps on its long-term care, particularly its community-based long-term care programs. Many states have caps on slots and other types of limitations. We do not have those. So that means that as the population of eligible individuals increases, we don't have sort of the natural checks in the system that other states have. And so that means that puts more pressure on us to manage in this environment. Many of us have been concerned about the potential growth in long-term care in Medicaid for a long time with the aging of the baby boom generation. I have my suspicions that we're really beginning now to see the full impact of that. That said, we have a number of initiatives designed to make sure that we're utilizing or providing those services in the most cost-effective way, in particular to make sure that the individuals enrolled in managed long-term care, which is a very high-touch care management model, are really targeted towards the people who need that type of care management the most. So first and foremost, you see that there's a change in the eligibility for that program for individuals enrolled in nursing home. This is permanent nursing home residents who have been in a nursing home for over 6 months while on Medicaid. We will actually, under this proposal, disenroll them from managed long-term care. They will stay in the nursing home in which they are residing. But the thought here is, do we really want to pay twice for care management, once for managed long-term care and a second to the nursing home as part of their nursing home rate? So that's an important part of how we balance the picture here. It saves about $74 million. Next up is social adult day, health benefit efficiency savings. Social adult day is a benefit unique to managed long-term care. We are going to expect in part of this is that managed long-term care plans will find a way to economize that service to make sure that individuals who need it use it as appropriate, but also look at other types of services as well. Next up is admin rate reduction, and this is really to reflect the fact that the program has grown substantially. We started out in 2010 with the program Managed Long-Term Care, which was about 15,000 people. We're now over 200,000. We made some minor admin rate changes, which is a fixed dollar amount that gets added on to the capitation. We haven't made one of those changes since 2014. So we're proposing another change, basically to account for the fact that as the program rises, that fixed dollar amount should be more than enough. In fact, it should be too much to cover the admin cost of the program. So we're trying to capture some economies of scale through this admin reduction. That said, we're also open to a conversation with the plans around regulatory relief, things that we could do to potentially lower their costs on the administrative side. We're also very hopeful for some consolidation in managed long-term care. Lots of plans across the state, particularly in the downstate region. We think consolidation would be a good thing, and we think this admin rate change will further encourage that. Speaking of consolidation, next plan is to limit LICSA contracts within managed long-term care. This is a further efficiency adjustment within the managed long-term care rates. This is to say to a managed long-term care plan, they can't contract with more than 10 LICSAs, probably generating as much conversation as any of our proposals. We also feel very strongly there are too many LICSAs in New York State, 1,400 or so. Very difficult to provide regulatory oversight of those institutions or those organizations. Also very difficult for those organizations to participate in value-based payment when they are very small, with a small number of individuals. Way more choice than is actually necessary in our view. That said, we are going to implement this in a thoughtful way. Plans will be able to seek hardship flexibility if they aren't able to either get to the 10 or can't get to 10 by our target date of October. We are willing to grant them hardship waivers to allow us to allow for a consolidation that makes sense and that's smooth and doesn't put patients at risk. But that said, we definitely need to consolidate in this area. So those are the major long-term care ones. There's other ones out there as well, but I just wanted to highlight the bigger ones. Next up is managed care initiatives. Also very important. A vast majority of our services are in managed care, and these are really focused on the mainstream managed care population. Starting at the top is a comprehensive omnibus proposal on health homes. We are very interested in health homes now, our maturing program. We're interested in getting a couple of things. One, more people enrolled into health homes, and secondly is getting the maximum value out of health homes. So this is, as I said, a omnibus proposal that includes a number of different sub-proposals, including penalties and incentives for plans and health homes to enroll more people into the health homes who are eligible. Also, we are interested in giving health homes and plans more tools. And so one of the areas that we're particularly excited about in this is the idea to implement patient-level incentives for health home recipients. We think there's a great opportunity to better engage patients through these incentives. As part of value-based payment, a recommendation was made to waive the monetary limits on patient incentives that had been in contracts for an extended period of time. And our thought here is a great place to start using patient-level incentives is in the health home population. There have been some very successful programs, including one in New York City targeting patients with AIDS, HIV. And so we think there's definitely things that could be tried or replicated in that particular space. Next up is penalties for managed care organizations who fail to meet VUP targets. Upon an assessment of the penalties that originally were developed, was that actually the penalties were quite small for plans. So we're going to increase those penalties. This is an example of one where we actually hope we don't actually have to collect these funds because the plans actually meet or exceed the targets. We do know there's parts of the state where plans are farther behind in terms of particularly Western New York. So it's really important for plans to see that we're serious about the move to value-based payment, and we are going to up the penalties on plans who fail to work towards those objectives. Next up is a cap on patient-centered medical home payments. New York has a long history of supporting and incentivizing primary care providers to become PCMH accredited, and that's been very successful. We've also invested heavily in the move to PCMH, or our Advanced Primary Care APC model through DSRIP. And while we're excited about this as a budget savings measure, we've capped the amount of program, and amount of money, enhanced payments that goes into this program, but we've also are now going to tie it. Not only do you have to meet the NCQA accreditation standards, but you also have to move to value-based payment. It's an example of us trying to provide incentives both at the plan, the provider level, to move into value-based payment. I think you will see this as a theme going forward. Certainly VBP QIP is another example, but more and more of our programs and policies, almost any form of assistance any provider looks for from the health department, you're going to be looked to move into value-based payment. It is our #1 priority. And providers who refuse to move into value-based arrangements, will not find a very receptive health department in terms of assistance. Then there are other managed care initiatives as well. All right, some other initiatives. First and foremost, OMIG has an important new initiative, a multi-pronged approach to work with managed care organizations to really move to address fraud, waste, and abuse in the program and recover overpayments where appropriate. I think basically the message here is OMIG feels that managed care organizations have underinvested in their fraud, waste, and abuse efforts, and really is going to be putting pressure on those plans to up their game. So we're supportive of that initiative. Next up is transportation. Once again, multiple transportation proposals, particularly carving out the transportation benefit, using our central transportation managers to manage those programs more effectively at lower costs. We also have an increase in reimbursement rates for ambulances. That is a beginning implementation of a study that was completed a year or so ago. Next up is AR balances. We have accounts receivable balances that we're always looking to find ways to lower. We've had a lot of success in this area, but there's still more work to be done. So we have some additional proposals here to help us and support us in that effort. Once again, there are some other initiatives that generate additional dollars as well. So on the investment side of the ledger, not as much here to talk about. This is a very difficult, challenging budget environment for us. So there's not as much reinvestment opportunity. The one I would mention here, this is for 1819, is our opportunity to implement our First 1,000 Days initiative. We're very excited about First 1,000 Days. And it was mentioned in the Governor's State of the State. I want to thank all the stakeholders who came together to develop a 10-point plan. We have the opportunity to begin implementation in this fiscal year, assuming it makes it to the budgetary process, and you'll see the investment in this area grow into the out year. I would also say, it's not on this slide, but we have a proposal that in fiscal year 1920, a $44 million increase in our supportive housing budget. Supportive housing has really been one of our signature MRT programs, very successful. Recent study came out and showed just how cost-effective housing is for high-needs Medicaid members. So while we can't afford to make an increased investment in the program this year, we're targeting an investment next year. All right, so with that, I will turn it over to John Olberg to talk about minimum wage. John?
So minimum wage, obviously a very big initiative for the governor and the legislature that started to ramp up a couple of years ago. It's a multi-year schedule that's divided between New York City, downstate, and upstate, and it requires a substantial investment into the global cap. As I had indicated before, the year-to-year increase from 17-18 to 18-19 was $448 million for a total investment. Again, these are just state dollars, non-federal dollars, of $703 million in 18-19. You can see the bulk of those dollars will materialize in the home care program, and that will grow to over $1 billion in 19-20 according to our schedule. These dollars are really pursuant to the statute, right, to support direct salary costs and related fringe benefits. Any unused funds will be returned back to the state, and we've been organizing across the different involved state agencies to help enforce the requirements under that law, and to actually help with the unused funds recovery process, which you'll hear more about from us at the beginning of the year. Pressures and risks. The global cap is a very, rigorous, disciplined process. We take it very seriously here in the health department. Involves, many people within OHIP and across the health department, including our partners at the budget division. It's our job really to look as far down the runway to identify risks that we can, right? So we can stay solvent within the cap, and the more runway we have to work with, obviously, the easier it is to manage. But these 4 items are the ones that really have us most concerned at this point. There's, the pending federal DSH cuts that would, be devastating for hospitals. Congress is yet to actually restore those cuts. We're hopeful that we'll hear some good news there shortly, but that's a $1.2 billion gross impact in state fiscal year 19, growing to $2.6 billion annually when fully implemented. As Jason said, the MLTC growth rate is been running at around 14%. We're forecasting that growth rate will flatten out to 5%. We have to watch that very closely. Also, as Jason said, we watch very closely the pipeline of new drugs. We know that there are some gene therapy drugs that are about $500,000 per treatment. We'll have to watch how those drugs unfold within the program, and then just pharmacy spending and rebates in general.
So that's it. So if you do have questions further, please submit them to the MRT updates at health.ny.gov. Happy to answer any questions on this important topic. Dr. Zucker and I will be testifying a week from today for the hearing, so encourage you to check in for that. That's always a fun experience. So we'll, I'm sure, get a lot of questions from legislative committees as well on that. But obviously, we're just at the start of the process. Each house will be passing eventually, probably in early March, their one-house bills, and then that will lead to our eventual negotiation, and hopefully, once again this year, an on-time budget. So we'll be looking forward to getting through that process and on to the next phase, which is implementation of those initiatives. Also encourage you, if you're interested in our efforts in the past, each year there's a new wave of MRT initiatives. We post to the website our work plans, so you can check and see how we are doing relative to their status and of implementation. So I encourage you to go out to the MRT website. And then lastly, for those of you who are going to be joining us this week at the Learning Symposium, look forward to seeing you down in Staten Island. Very exciting opportunity to share best practices and hear from others, not only across New York, but frankly from all over the world, about efforts to transform care and move from a world of volume to value in healthcare. So very excited about that this week. So thank you very much, and look forward to answering any questions you might have.